A 32-year-old premenopausal woman underwent lumpectomy for a 2.5 centimeter, grade 3, ER-positive, PR-positive, HER2-negative invasive ductal carcinoma with 2 positive axillary lymph nodes. She completed adjuvant chemotherapy and remains premenopausal based on biochemical testing. You are discussing adjuvant endocrine therapy options. Tamoxifen alone is the preferred adjuvant endocrine therapy for this patient due to her premenopausal status. Answer: false. This patient is considered high risk due to lymph node involvement, tumor size, and young age, less than or equal to 35 years. For high-risk premenopausal patients, ovarian function suppression combined with either an aromatase inhibitor or tamoxifen is favored over tamoxifen alone. The SOFT trial demonstrated that among women younger than 35 years who mostly received chemotherapy, tamoxifen alone provided similar freedom from breast cancer rates at 5 years compared to OFS-containing regimens. Answer: false. The SOFT trial showed that among women less than 35 years, 94% received chemotherapy. Freedom from breast cancer at 5 years was lower with tamoxifen alone at 68% compared to tamoxifen plus OFS at 79% or exemestane plus OFS at 83%. If OFS is chosen, surgical oophorectomy is considered an inappropriate method compared to GnRH agonist therapy. Answer: false. Surgical oophorectomy is an appropriate alternative to ongoing GnRH agonist therapy for OFS, especially if the patient tolerates GnRH therapy well, does not desire future fertility, and prefers a permanent method. Based on the joint analysis of soft text trials with 13-year follow-up, does choosing exemestane plus OFS over tamoxifen plus OFS offer a statistically significant overall survival benefit in the HER2-negative subgroup who received chemotherapy? Answer: no. While the joint analysis showed a numerical improvement in 12-year OS, absolute benefit 3.3%, favoring exemestane plus OFS in the HER2-negative prior chemotherapy subgroup, this difference did not reach statistical significance, HR 0.85, 95% CI, 0.70 to 1.04. Is ovarian irradiation a commonly recommended method for achieving OFS in contemporary clinical practice for this patient? Answer: no. Ovarian radiation is rarely used in contemporary practice due to side effects, including potential radiation exposure to surrounding normal tissues like the bowels, and limited data suggesting potentially lower efficacy in younger women. Should this patient be advised that contraception is unnecessary if she is receiving OFS with a GnRH agonist? Answer: yes. Ovarian function suppression via GnRH agonist, assuming compliance, is considered adequate for contraception. Tamoxifen, however, does not prevent pregnancy. A 47-year-old woman, premenopausal at diagnosis, had a 1.8 centimeter, grade 2, ER-positive, PR-positive, HER2-negative breast cancer with no nodes. She received adjuvant chemotherapy due to an intermediate-risk genomic assay result and has been amenorrheic 6 months post-chemotherapy. You are determining the appropriate adjuvant endocrine therapy. Because this patient is currently amenorrheic after chemotherapy, she can be considered postmenopausal for the purpose of selecting endocrine therapy. Answer: false. Chemotherapy-induced amenorrhea is not a reliable indicator of permanent menopause, especially in women under 50. These patients may recover ovarian function and should be treated as premenopausal unless proven otherwise biochemically. Initiating an aromatase inhibitor alone is a safe and effective option for this patient, given her current amenorrhea. Answer: false. Using an AI alone in women with potential for ovarian function recovery, even if currently amenorrheic post-chemo, is contraindicated due to the risk of ovarian stimulation and worse outcomes. If an AI is used, it must be combined with OFS, GnRHA, or oophorectomy. Data from the SOFT trial subset of patients who did not receive chemotherapy showed a significant overall survival benefit when OFS was added to either tamoxifen or an aromatase inhibitor compared to tamoxifen alone at 8 and 12 years follow-up. Answer: False. In the soft subset not receiving chemotherapy, lower average risk, there was no improvement in distant recurrences or overall survival with the addition of OFS to either tamoxifen or exemestane compared to tamoxifen alone at 8 and 12 years follow-up. Is tamoxifen alone considered an appropriate initial endocrine therapy choice for this patient, assuming she is treated as premenopausal due to the chemotherapy-induced amenorrhea? Answer: yes. For women treated as premenopausal due to chemotherapy-induced amenorrhea, particularly those not clearly meeting high-risk criteria post-chemo, tamoxifen alone is an appropriate option. She received chemo, placing her in a potentially higher risk category where OFS could be considered, but tamoxifen alone remains a standard choice if OFS is not pursued. If this patient starts tamoxifen alone, could she potentially transition to an AI later without OFS? Answer: yes, if she remains amenorrheic on tamoxifen and subsequent biochemical testing, both FSH and estradiol levels, confirms postmenopausal status, transitioning to an AI alone after several years of tamoxifen is an appropriate strategy. Does the administration of chemotherapy itself define this patient as higher risk for the purpose of mandating OFS according to the provided approach? Answer: yes. The approach defined high-risk patients as those for whom chemotherapy is indicated based on nodes, size, genomic assay, etc. Since she received chemotherapy based on a genomic assay, she falls into the category where OFS with an AI or tamoxifen should be strongly considered.
What topic should we bite next? Comment below. Subscribe and hit the bell for instant updates. Explore our channel for more. Find more info at HemOncBytes.com. Stay current, stay curious.